Super. Vish, thanks for your comments there. One of the things we really try and do in our unit is, if we're presenting stuff, we want it to have an impact in practice. So if anything, any of us have ever said has influenced practice or improved care for patients, we're doing our job. So that's absolutely fantastic. I'm going to be talking about the NICE self-harm guidelines today. So I'm delighted that they came out earlier this month. I was, on this occasion, the expert topic advisor to the guidelines. And what that meant is I attended all the committee meetings, advised the committee, advised the technical team, and hopefully helped shape the final products. I'm really delighted that we were able to get the guideline out. And over many years, I like to think, what are the big frontiers in self-harm care? What are the big frontiers in self-harm care, particularly in emergency departments and general hospitals? Because my training is liaison psychiatry. That's one of the settings I'm really concerned about. What are the big frontiers? I think one of the battles was making sure that people actually got assessed. So when someone hurts themselves, presents to hospital services, we've got a kind of duty really to, I think, make sure they get a proper assessment. And I think over the last 10 to 15 years, we've kind of won or beginning to win that argument. So people getting better access to assessments. But then, if you like, the last frontier or the next frontier is aftercare, and that's what we're talking about today. And I think there's a real opportunity there to make a huge difference. So the guideline came out earlier in the month, and as Jonathan kind of hinted at, basically updated the two previous guidelines and tried to kind of merge them together. So we had a short and a long-term guideline. This guideline merges the two of them together. So that was that guideline. But the other thing I just wanted to kind of reflect on is that I like guidelines. So I've calculated, I spent probably about 15 years of my life on one guideline or another, dating back right to the first kind of self-harm guideline. I was a kind of advisor on that one. Self-harm guidelines, self-harm quality standards, and more recently the depression guideline, which you'll hear about in a second. I think guidelines are a really good thing. I think they have the potential to reduce variations in care. No, that's a problem in self-harm. Improve the quality of kind of evidence-based care that patients have access to. They can empower patients, empower service users. So if we've got a guideline, we often have a bit where, what this means for your care. And certainly with some of the guidelines, and it's been the case with the self-harm guidelines, they drive policy. So if we've got a self-harm guideline in an area, we can go to ministers, we can say, look, what are you doing in this area? So I think guidelines are a great thing. We can talk about implementation of guidelines in the discussion if we have time, but I think guidelines are great. But the other thing I thought, and what you're going to get a bit of, is me reading from the new guideline about assessment and aftercare. But I thought I'd also just give you a quick heads up about what the guideline development process is, and it's quite a long process. It's 2 years. For the depression guideline, it was actually 7 years. That's the longest guideline in history. For the self-harm guidelines, it was around 2 years. And it's quite a kind of detailed process where the scope of the guideline goes out for stakeholder comment, and many of you I know will have commented on both the scope and then the eventual guidelines, and it goes through various kind of iterations, but it's a kind of painstaking process from NICE. What does that mean in practice? It means committee meetings, lots of committee meetings that I've attended over the years, regular committee meetings where we're discussing the evidence. Of course, in the past, they were face-to-face. More recently, they've been virtual. This is the actual room where some of the initial discussions about the depression guideline, not the self-harm guidelines, which was mostly virtual, took place. So what do we discuss at those meetings? Well, the first thing we discuss is the hard science. So the most important thing about NICE guidelines is they're evidence-based. So, people are looking at things like these are forest plots where you're looking at the results of trials. but also looking at cost effectiveness, because that's a really important aspect of what we're recommending. You know, if we recommend it, it might make a difference, but does it make a difference that actually saves the health service money in the long term? Because those are the things that are much more likely to be implemented. But Jonathan's already talked about, you know, in some areas, and especially in some areas of self-harm, there's a lack of evidence. So what do we do there? There, it moves from, if you like, hard science to dark art. And what you've got then is, if you like, the people around the table having a kind of consensus decision on aspects of care. So some of that nice self-harm guideline that came up earlier in the month is based on hard science, but some of it is based on consensus. So bear that in mind when you look at the recommendations. Aftercare. Now, aftercare is really important, but sometimes good aftercare is defined by what it isn't. So I just wanted to put up some examples of poor aftercare. So here's some data from Jane Cooper's, you know, really well-known study when she went to 32 hospitals quite a few years ago now, and looked at variations in care. And care was variable. And this is the rate of referral for mental health follow-up. And you can see it just varies from hospital to hospital. And this isn't due to, you know, variations in case mix or other things. Some of this is cultural. Some of this is historical. Some of this is based on what the services are available. So variable care, variable aftercare isn't good aftercare. The other thing that isn't good aftercare is fragmented aftercare. So this is the Samaritans' really nice report called From Push from Pillar to Post, describing some self-harm services in some bits of you know, England, and you know, it's a really apt description. You know, this fragmented care where people are going from bouncing around different bits of the service. So that's not good aftercare either. And of course, aftercare that's stigmatizing. I don't need to tell people on this call, aftercare that is stigmatizing isn't good care either. So there's some things where aftercare is poor. What about good aftercare? What about you know, good aftercare, and what have we said about it in the guideline? So Jonathan has kind of mentioned some of this. You know, the first thing about aftercare is you get in there quickly. Why do we get in there quickly? Many of you have seen me put up this graph before, where, you know, we're looking at days to repeat self-harm. So if someone repeats, how quickly do they repeat? The answer is really quickly. So a third of people, if they're going to repeat, do so within 1 month. 10% of people who are going to repeat do so within 5 days. So if you're going to get in there quickly. 48 hours is the recommendation in the new NICE guideline. That's partly borrowed from this work. It's partly borrowed from the post-discharge work, and it's features in other kind of post-discharge NICE guidelines as well. 48 hours. If you're going to get in there quickly. But the other thing we talked about in terms of aftercare is you've got to communicate the plan with people as well. You know, often plans aren't communicated, and involving family members and carers is a kind of key principle as well. So communicate the plan as well as getting in there quickly if we're talking about aftercare. It's not just the risk of self-harm, of course, you know, highest early on. The risk of suicide, sadly, is highest early on as well. So colleagues in Oxford, Caroline, who's also on the call, did this study, 3 centres in England, basically looking at the risk of suicide after self-harm, which we know is greatly elevated. But if you look at the risk of suicide in the first month after someone presents, you know, to one of our emergency departments, to one of your emergency departments, the rate is about, you know, almost 200 times the rate of suicide in the general population in the first month. And then it's still high months afterwards, but that, you know, if you want to get in there and make a difference, get in there quickly. Really important message. That's the initial aftercare, but I also wanted to kind of touch on interventions as well. So interventions, the first thing about interventions is, you know, recognizing self-harm isn't a diagnosis, recognizing that, you know, heterogeneity, if you like, the fact that self-harm is many different things, it's a spectrum. And actually, one of the really important things is, you know, take into account other things that might be contributing and treat those. And then nice, I've got so many guidelines now that they can kind of co-refer, they can kind of cross-refer to some of the other guidelines. So look, take into account what's going on, what else is going on, use the guidance where it's available to perhaps handle those the conditions. But also this role of kind of talking therapies. And we talk in the guideline about cognitive behavioural informed psychological intervention. Basically, in terms of the actual research, it was a wide variety of things. Some of it was CBT, some of it was problem solving. The Elf Guthrie trial was IPT, interpersonal psychodynamic therapy. Basically, I mean, all of them have CBT type principles, but it's quite a mix here. Get in there as soon as possible, 4 to 10 sessions. Where does that come from? It comes from what was reported in the trials, and also the economic modelling to say what was kind of cost effective, and it's tailored to persons' needs and preferences. In some ways, quite a surprise for some. There wasn't a lot on young people, but one of the things that we did recommend as a committee is thinking about DBTA, because there was a bit of an evidence base there. But I think partly that was because there was a lack of evidence base for many other trials, so needing more research there, but also making sure people who are delivering the therapies are appropriately trained and supervised. How do we train and supervise our staff? A lot of you do a brilliant job in that area, but we've also got the competence frameworks that we developed a few years ago now from Health Education England, basically looking at the knowledge, skills and attitudes we might expect staff to have. So we encourage services to, if you like, audit their own training against these, have a look at areas, have a look at other areas which they might want to provide bespoke training. So making sure that the workforce we've got, people who are on the ground, are appropriately trained but also supervised. We've heard a little bit already in the previous 2 presentations about the pivot to remote and kind of digital interventions. What's the evidence? What's the evidence out there? Well, it's really interesting. Academics, I'm an academic. Sometimes we look at the same evidence base and we come up with different conclusions. So systematic reviews of digital interventions for suicidal ideation and self-harm. My friends and colleagues at the Black Dog Institute in Australia, really enthusiastic. Let's go for it. Other colleagues, a bit more cautious, thinking that we need a bit more evidence. What's my own view? I think what the last 2 years have taught us is sometimes digital interventions are necessary. I think now what we're finding is some people still have a preference for remote and digital interventions, and I think someone described it as a blended or a hybrid model. That's where we're going with both its pros and its cons. So I think we're in the hybrid or blended world, and we need to learn how to do each type of assessment, each type of intervention better. But sometimes I'll get the people say, well, it's better to do something rather than nothing, isn't it, Nav? And the answer is no, actually. The answer is no. So we've talked about very brief interventions for self-harm. Quite a few years ago now, we did a postcard trial in Manchester, just a pilot trial, and people who got the interventions where we rang them up and sent letters to people actually had higher rates of repetition. And so this idea that you can't do any harm, can you? I think is mistaken, and all treatments have their side effects. So I think if we are offering interventions, they need to be evidence-based. Here's a really interesting study. I encourage you to look it up. One of the biggest trials in suicide prevention, suicidal behaviour ever undertaken. It was basically people with suicidal ideation. So it isn't strictly speaking people with self-harm, but they randomized a huge number of people to a kind of care management kind of telephone call with outpatient follow-up type intervention, or an online DBT based skills training package. And basically there was no evidence for effectiveness for these interventions. And for the skills training, the DBT skills training, the rate of future self-harm events was actually higher than usual care, statistically significantly higher. I mean, it's a small difference, but that was statistically significant. And you have to ask yourself what that's about. And partly one of the things here in this trial was about implementation. So many of the people randomized to these interventions didn't get them. So people randomized the online training, didn't bother logging on, didn't engage in, really like the focus in both the talks about, how do we engage people? How do we get them in to that follow-up? Because sometimes people who self-harm, might be difficult to engage. So the engagement is crucial. And I think, in this trial, it was simply a provision of care rather than any attempts at active engagement. So that's one thing. And the other thing is the kind of failed promise kind of hypothesis. And you see this in bits of research on self-harm, where you're promising an intervention, but actually then the reality perhaps doesn't meet patients or service users' expectations. And that's actually bad for people. If you promise something and don't deliver it, I think that can be harmful. So not all interventions are the same. Talk quickly about safety plans. We all know what safety plans are. I know one of the previous sessions you've had in Leah's and Caroline's kind of program here, you talked about safety plans, really good session. I think the recordings are available. A lot of people say, well, why is that only a consider recommendation? And that's nice language, if you like, for when the research trial evidence isn't, cast iron and robust. And actually, there aren't that many randomized controlled trials of safety plans. There's some very good observational work from Barbara Stanley and colleagues who originated all of these, but that's why it's a consider. It's because research evidence base isn't as strong as many people think. But do I think they're a good idea? Yes, I do. And in the NICE guidelines, there's quite a lot in there about the content of safety plans, the kinds of things you might want to include in the safety plans. There's also, I think, some useful things about accessibility. So, the safety plan needs to be accessible. It can't just be kind of hidden away somewhere. But probably the most important thing about the safety plans, I think that's in the guideline, is this thing that comes up again and again. So it's this thing about the how in self-harm care is as important as the what. So, a few years ago it was about assessment. Now what should we ask in our assessments? And we know roughly what we need to ask in the assessments, but actually it's the how, the compassionate assessment, that's more important than the exact content. The same with risk assessment. We can talk about that, another time. Or safety plans. It's the how. So the collaborative, compassionate care. Otherwise, it becomes a kind of another tokenistic bit of extra process. So I think that's a really important bit in the guideline that I'd like to emphasize. Some other kind of random kind of bits from the guideline that I just wanted to kind of highlight that I think are really relevant to aftercare. Don't exclude people. I think a lot of kind of self-harm care in the past has been predicated on excluding people. And I'd argue that psychological interventions are suitable for most people if we can engage people and keep them in therapy. Don't resort to medication alone for self-harm reduction. Obviously, if they've got an underlying condition, a major depressive disorder, a psychotic disorder that's amenable to medication, we know medication works for those conditions, you would use it, but don't use drug treatment as a specific intervention for self-harm. Continuity, really important. It's continuity of staff. So the person you see in the emergency department doing your assessment, wouldn't it be great if that person would be the one doing the follow-up and that person was the one providing your 4 to 10 sessions of therapy, but also informational continuity. So does one electronic care record system talk to another? Is the GP kind of informed? And an organizational continuity. So when people shift between services, is there information kind of shifting with them? Service users hate it when they have to repeat their story over and over again. I'm thinking about safety as well. So this is, if you like, immediate aftercare, thinking about autonomy and using least restrictive care. I think that's a really important principle. I know many of you in the audience might be prescribers and thinking about safer prescribing as part of aftercare as well. So, thinking, if people are taking medication and they have previously self-harmed, how we make that as safe as possible, and that leading into perhaps a wider discussion around availability. So here we go. Here's a summary. The summary is almost as long as the talk, but bear with me because I think this has got most of the important stuff on it. Clinical guidelines are helpful. I'm a big fan. Other people are less big fans, but I think they improve quality, reduce variability, inform policy, and give service users a voice. That initial aftercare needs to be timely, get in there quickly, but it needs to be collaborative, and you need to tell the service user and the family what the plan is. Any treatments, any longer interventions, take into account the underlying conditions. Remember, self-harm is just a kind of a behaviour with a wide variety of underlying conditions. We've really got to work hard, I think, during the next 10 years. One of the things I'll really be pushing is making talking treatments available and making sure that we've got staff who are trained and supervised, because it's no good just having staff that are trained, but you know what it's like. Many of you from frontline practitioners, complex clinical scenarios, we need good supervision. Safety plans, I think they're a good idea. I think we do need more research into safety plans, but we also need to think, locally about how we implement them. Let's not have care that excludes people. Let's have care that's not solely medication based or unduly restrictive, and let's think about how we can improve levels of continuity, although I recognise challenges around that. And safer prescribing and wider access to means also needs to be considered. And the other thing we love to do is just, acknowledge all our really brilliant, hardworking staff. Some of them are on the call, some of them have been introduced, but many are here in Manchester, working tirelessly. So thanks very much for listening.